At this point, I think we can move on and get to our first presenter, who is Dr. Vanessa Hinson. She has a medical degree from the University of Hamburg School of Medicine in Hamburg, Germany, and she has that wonderful accent. 20 plus years of experience as a neurologist. She's the director of movement disorders at the Medical University of South Carolina. She has written or contributed to more than 25 articles in her field. She's earned the Patient's Choice Award as well as the Compassionate Doctor recognition, and we are very, very pleased to welcome her here today.
Well, thank you so much to the Parkinson Foundation, I'm learning quickly, for having me here today. It's a pleasure to be in Buffalo. I have many friends here, and I hope to make many more today. So thank you for allowing me to speak on a very important topic related to Parkinson's disease, which are the non-motor symptoms, and we will explain in a little bit why it's so important to really focus in on these symptoms. But since I have the honor to be the first speaker today, I would like to go over some facts so that the newcomers in the room who have not done this symposium for 18 years, like some of you might have the same privilege of knowledge than all the other people in the room. So first of all, Parkinson's disease is very common. It is the second most common neurodegenerative disorder that affects people. And the first one would be Alzheimer's disease. We're all glad we don't have that. There are at least 1 million people in the United States living with Parkinson's disease right now. And every year, about 60,000 more people get diagnosed. And if you look at all Americans and kind of count out 5 at a time, 3 of them in their lifetime will be affected by some type of nervous system disease like Parkinson's disease in their life. So we really should invite the public to join us here for such a symposium. Now, again, brief introduction. Let's understand what is causing Parkinson's disease and what is Parkinson's disease. In the majority of cases, we believe that there are genetic and environmental factors that contribute to a person develop Parkinson's disease. And what that means is that most people who later on acquire Parkinson's disease have a degree of a genetic predisposition to getting the disorder. But that genetic predisposition alone does not give you Parkinson's disease. The stick figure here is happily living without Parkinson's disease, even though they have that predisposition. Here's another thing that we call environmental factors. There might be something in the environment, and it's very hard to pinpoint what that is, that one is exposed to, but that exposure alone doesn't give you Parkinson's disease. It is the two coming together, the genetic predisposition, and then something in the environment that you're exposed to that then gives you Parkinson's disease, all right? So 2 things coming together. Good example is, I always think about the veterans that are treated in Charleston, South Carolina, at the Veterans Hospital. Some of them were exposed to Agent Orange during the Vietnam War. Not every soldier who had Agent Orange exposure acquires Parkinson's disease, because some of them don't have the genetic predisposition. But if they did go in there having that vulnerability and then get exposed to Agent Orange, boom, 2 things come together, and they later, not as a young person, but later on in their 60s, develop Parkinson's disease. So on a simplistic level, this is how we look at that. So here's another look at the story. You know, when these factors come together, let's say the Agent Orange and that predisposition, what actually happens at the brain level? So we believe as we get older, like we said, that veteran would not develop the tremor right after they return from the war. It would be in their 60s or 70s maybe. So as they age and they're exposed to these environmental toxins, there is some damage to the energy factories of the cells. We call them mitochondria. These energy factories, when they're damaged, they emit toxic waste. Scientists call that free radicals. These free radicals kill brain cells, such as those in the dopamine system, right? And we all know Parkinson's has to do with dopamine, amongst many other things. But these free radicals that are set free by the damaged factories, okay, they produce cell death of certain cell populations. So what do the genes have to do with that? Well, if you're genetically predisposed to Parkinson's disease and you age, there are certain proteins in your brain that clump up, all right? And your garbage disposal system that's supposed to get rid of the protein is not functioning well. That's a problem, because when these proteins, and the main one that we know of is called alpha-synuclein, clumps up in the brain cell, that brain cell will die. All right, so we have two things. One is the damaged factories emit the toxic waste. Those free radicals kill brain cells, and then that toxic protein clumps up. So what's the deal with this protein? And if you go on, you read up on Parkinson's disease, all you hear about is this alpha-synuclein. It's like, what the heck is that? Well, it's something that we all have in our brains. It's actually normal. Everybody has it. Everybody has alpha-synuclein, believe it or not. And it does play a role when cells talk to each other. So it's a good thing to have around. However, when it becomes sticky and misfolds because of that genetic predisposition and the toxins, that's when it becomes a problem, because your brain cannot get rid of it, right? You step on that piece of gum, you can't get rid of it. It's going to stick with you. So that's the problem in Parkinson's disease. So what we've known for a long time, and what we used to focus on for a long time, is that that sticky protein damages a particular population of brain cells called dopamine neurons. And we know that when you lose at least 50% of them, you develop the typical signs of Parkinson's disease: tremor, slowness, stiffness, trouble walking, the typical motor symptoms, which is not what my talk is focusing on today. But that happens when those dopamine cells are damaged by that particular protein. And this is kind of where we left it for many years. You know, Parkinson's, dopamine gone, tremor, end of the story. But it turns out that it's not as simple as that, because that story, even though easy to understand, would not explain why there are so many other symptoms that are not tremor, that are not slowness, that are not stiffness in Parkinson's disease. And you probably can tell me about them more or better than I can tell you about them, because you're experiencing them. Many people with Parkinson's suffer from non-motor symptoms. That means symptoms that have nothing to do with movement. Some of them are mood-related, anxiety, depression. Some of them have to do with thinking skills, being not able to multitask as easily, having some memory problems, word finding. Some of them have to do with the GI tract. Some of you might be constipated, chronically constipated. Some have to do with swallowing, having excessive saliva in your mouth, urinary issues, sleep problems, dizziness, lightheadedness, syncope, pain. Any of that probably sounds familiar to many of you. So we can't just pretend that Parkinson's is a disorder of three symptoms: shaking, stiffness, and balance problems. It is not. It is much more than that. So let's talk about these very important symptoms. First of all, why do they occur? If that sticky protein kills those dopamine cells, but dopamine cells don't cause these symptoms, why do they occur? Well, this is explained by what the neuroscientists have discovered more in the last 10 years or so, is that that sticky protein actually does not at first accumulate in the brain, but actually a different part in the body, namely the gut, all right? The first footprint of Parkinson's that scientists can find is in the gut, all right? So that explains why many people have constipation about 20 years before they ever develop the motor symptoms of Parkinson's disease. That wouldn't make any sense if Parkinson's were purely a brain disorder. But it is not. We find that protein first in the gut, and then we can kind of track its path upwards to the brain. And even within the brain, it doesn't hit the motor symptoms, or the motor systems, I should say, right away. It first goes to the lower brainstem and then kind of marches up. Well, here in the lower brainstem, we have some centers that regulate your blood pressure, that make sure that when you stand up, your blood pressure doesn't go low and you don't get lightheaded, and so on and so forth. So when those centers are affected, well, guess what? You might feel dizzy when you first stand up out of a seated position. That's a symptom of Parkinson's disease. The sleep centers in the brain are often affected early on. The protein sits right there. When it affects the sleep center, you might develop vivid dreams. You might talk in your sleep. You might thrash around. You might fall out of bed. You might hit your spouse in your sleep and didn't mean to do it. So all that is explained by that protein clumping up in multiple areas of the brain that have nothing to do with tremor, slowness, and stiffness. They also clump up those proteins in the very top cortex of the brain. This is where our thinking centers are, which is why so many people with PD have trouble with multitasking, focus, attention, and so on and so forth. So we finally, as scientists, are ready to understand that it's not as simple as a little dopamine story. Yes? Yeah, I think we need to upregulate, actually, if you just turn up the volume a little bit. Tell me if that helps. That's maybe a little overdoing it, but all right. Give our IT person an up or a down in the back and let us know when it's just right. All right. So here we keep going. Now, let's think about the timeline of Parkinson's disease, because not all these symptoms happen all at once. Thank goodness, right? That would be overwhelming. We're already overwhelmed with the diagnosis of Parkinson's disease when we get it. So if you think about Parkinson's disease, most people get diagnosed when they have the tremor, the stiffness, and the slowness. And that's really what we call, as simplistic clinicians and doctors, the onset of Parkinson's disease. But when you think about it, that same person might have had 20 years worth of constipation and maybe some changes in their mood and maybe some changes in their ability to multitask that nobody diagnosed as Parkinson's disease. However, had there been some type of blood test or what we call a biomarker, maybe they could have been diagnosed 20 years early, and maybe we could have done something about the progression, and maybe Parkinson's would have never hit the brain. So I find it amazing that we diagnose a disorder when it's well on the way, because we have to wait on these visible symptoms to appear. So hopefully in the future that will change. Now, let's think about how Parkinson's affects quality of life. The then Parkinson's Disease Foundation, several years ago, did a survey amongst 228 people living with Parkinson's disease and asked people what their most uncomfortable symptoms were or what was most in their way of feeling well. And actually, it turned out that the non-motor symptoms of Parkinson's disease were rated by most people as affecting their life much more and downgrading their quality of life more than the motor symptoms. People would say things like, I'd rather have a resting tremor than be very depressed, lose interest in activities, and pass out when I'm standing up. So very interesting to know about. Also, when you think about elderly folks with Parkinson's disease and you examine why some of them get placed in nursing homes, it turns out that the non-motor symptoms, and especially the cognition and related problems, are usually the reason for any admission, should there be one, to a nursing home in people living with Parkinson's disease. So these symptoms are very important. Now, also important to know is that they usually do not respond to the medications that we most commonly use to treat Parkinson's disease. Most of you are probably on carbidopa, levodopa, Sinemet, right? Some dopamine drug, one form or another, right, Terry? There's many of them now, which is great. But these drugs, while they're very, very effective for tremor, slowness, and stiffness, do not treat anxiety, sleep problems, and the other non-motor symptoms that we talked about. They do not, all right? So we need to go over these symptoms more in detail and let you know how we as clinicians approach these symptoms. So some of that might actually be with medications, just not dopamine medications, but hopefully your cereal bowl in the morning doesn't look as big as this one. But some of that might also be with tips and tricks that are outside of the medicine tablet realm. So let's start out with the GI symptoms. And again, I want to emphasize, we believe that Parkinson's footprint is first found in the gut system. So it deserves to come first here. And I also want to emphasize that sometimes people think, well, you know, constipation, that's a trivial symptom, all these GI symptoms, what do they really matter? It doesn't even affect the brain. These GI symptoms are very, very important, and they do matter. Constipation, for example, can lead to abdominal pain and even impaction. We have people have to be admitted to the hospital because their constipation got so severe that they had to go in for a medical procedure to clear that up. We do not want that. And chronic pain in your abdomen is not a pretty thing. It's going to keep you depressed, it's going to keep you from exercising, and so we don't need that. Swallowing problems, big risk for aspirating your food, letting it go down into your lungs instead of your stomach, big risk for pneumonia. We should not take that lightly. Drooling is a big problem, can affect your dental health. It can be in your way of speaking clearly. It can be socially embarrassing. We need to take that seriously as well. So let's start out with constipation. We know that many people who have chronic and severe constipation actually go on to develop Parkinson's disease. The Honolulu Asia Aging Study, which is a very, very large study of people's aging process outside of Parkinson's disease, found those that had chronic constipation had an almost 3 times higher risk than people who were not constipated in acquiring Parkinson's disease. That's a hard fact. Oh, goodness. That was my attempt to time myself through this presentation. However, it is not over yet. I'm going to have Chris time me here. That's going to be better. Now, what we know is that 80% of people living with Parkinson's disease, if you measure their colon transit time, it will be slowed. So 80% of people have, a verifiable slowing of their colon transit time if they live with Parkinson's disease. So those are important to know about. How do we manage constipation? Well, like you've heard me say before, I like the simplistic approaches. So first, let's remove the obvious obstacles. So there could be medications that your doctors are writing for and exposing you to that are not very helpful, that are actually hurting you when you have constipation. First of all, narcotics, anything that has codone, odone, anything like that in it, that's a bad thing when you're constipated. It's going to make it worse. Any sedatives, benzodiazepines, Valium, Ativan, clonazepam, all those things make you constipated. There's certain antacids that can contribute, iron supplements, but here you have it. Certain Parkinson's medications, such as amantadine and artane, make you constipated. So that might be a trade-off. They might be very helpful for you in other ways, but if you have severe constipation, you might want to talk to your doctor about coming off of those because they're not good for you in that particular scenario. The other very easy to address issue is that most of us don't drink enough water, all right? And if you think about your stool being moved very slowly to your gut, if you don't drink enough water, it's going to dry up and just sit there and stop you up completely. So we say at least 6 to 8 8-ounce glasses of fluids per day. Water is best. Diet drinks are worse, the worst thing you can do. In the diet drinks with the artificial sugars, they act like diuretics. You're going to pee that stuff right out. So basically, you have a negative fluid balance after that because you keep going to the bathroom all the time. Not good. Just stay with water. The other issue is that if we don't exercise, our gut is going to slow down with the rest of us. So exercise, very important here. And then, of course, diet, and we'll have a talk on healthy diet a little bit later on, but you just need to load up on the whole grains, vegetables, and fruit, okay? So just as an example, in the morning, any type of hot food in the morning stimulates your gut. So a hot bowl of oatmeal is a good thing. You can sprinkle some flaxseed on that, maybe add some dried fruit, dried prunes, dates, or figs to that. followed up with a glass of Sunsweet prune juice. The Sunsweet is a brand that has a lot of still fiber in it, so it's not just, kind of artificial juice. It's the real stuff, and it really gets you going in the morning. And then there's something that my patients have taught me, which is called the constipation paste. And this recipe works really well. Unless you're diabetic, this is a really good suggestion. It's based on pitted prunes, raisins, figs, senna tea, brown sugar, and lemon juice. When you brew this stuff up together, it gives you the consistency of about applesauce or something like that, and the color of applesauce. You might not like that color, but that's what it turns out to be. And if you eat or take about 1 to 2 tablespoons a day, it's a very natural way of, keeping constipation away. So it's not just 1 apple a day, it's like 1 tablespoon of anti-constipation paste a day. It is actually the most popular recipe in my practice. People are like, yeah, you can keep that cinnamon, but could I have the recipe for the anti-constipation paste? Here it is. So we'll make it available maybe on your website here in this area for you to try. Now, there's also certain medicines for treating constipation that in Parkinson's disease are sometimes kind of counterproductive. For example, such a commonly used thing like Metamucil or other forms of psyllium, they actually, in Parkinson's disease, can create kind of a fiber ball, because they're fiber essentially, because your gut is so slow, it can't push the fiber through, so it can make it worse, especially if you don't drink enough water, right? So you already have a risk of stopping up, you take some Metamucil that creates a fiber ball, and then you have more of a problem. So we try to stay away from that. We also stay away from laxatives that's supposed to stimulate your gut, like Dulcolax, because you become dependent on them, and your gut just turns lazy and doesn't do anything by itself anymore. So what is okay to do is take stool softeners like Colase that just draw the water into the stool, the water that you drink, the 6 to 8 glasses, they go right in there, which is great. And then Miralax is actually the one that is best studied in Parkinson's disease. Very well tolerated, does not cause your gut to slow down. Now, some of our patients are so constipated they have to see a GI doctor for that, and many of the GI physicians will prescribe a medicine called Amitiza that was initially brought to market for problems with irritable bowel syndrome. But just to know, there's safe things, and then there's things we try to stay away from. Let's move on to swallowing problems. Like we said, if you have swallowing problems with Parkinson's disease, food can go down into your lungs if you don't swallow properly. That is a big problem. Food doesn't belong in your lungs. The lung knows that, so it creates inflammatory tissue around that, and you can have what we call aspiration pneumonia. So it's a big problem. That is usually something that only occurs in advanced Parkinson's disease, but we take it very seriously. Now, if you do notice any type of swallowing problem, I want you to tell your doctor about it. We will refer you to a speech-language pathologist and possibly an ENT physician, and they will do a test called a modified barium swallow. So what they will do is they will give you some white liquid to drink and then take x-rays as you drink the liquid to see whether that liquid goes down where it's supposed to go or whether it's going into your lungs. Now, that liquid is safe in your lungs in small quantities, so that's not going to cause you pneumonia. But if we see it's going down the wrong way, we need to do something about it. And so there are actually really good strategies that the speech and language pathologist, even though they're called speech and language, they treat swallowing. That's another thing that's, it's like, what? I don't have a speech problem, I have a swallowing problem. Same people treat that, all right? So the speech and language pathologist will put you through exercises that would not only strengthen your swallow muscles, but will also teach you techniques such as tucking in your chin while you're swallowing that will keep the food from going down into your lungs. No medication necessary here. These are really basically physical therapy for your swallowing muscles. Very effective. So strengthening those muscles. They might also ask you to change your diet. Some of our patients have a lot of coughing when they drink liquids, and so the ST person might recommend that they add some powder to those liquids to thicken them a little bit so that they don't go down into the lungs as easily. Now, in very rare cases, the the issue is so important to address that we say swallowing is no longer safe. We are recommending that you work with a little PEG tube, which is a tube that is inserted directly into your gastrointestinal system through the stomach wall. It is not something that you will carry through your nose or throat, so it is very minimally visible, essentially, from the outside, and very, very much important to keep nutrition up while keeping you safe and keeping you from having pneumonia. Now, an important question, of course, is, well, you're telling me I can't swallow. What about my pills now? You know, I don't want my pills in my lungs. Well, that's a very valid concern, and also occurs sometimes when you go in and have surgery of some sort, and the surgeon says you can't have anything by mouth, you know, for a specified number of days or hours or time. And so luckily, there's some ways to get around that. So there is an orally disintegrating form of levodopa called Parcopa. It's a little orally disintegrating tablet that you don't have to swallow that will dissolve itself in your mouth. That's one way to deal with it. If people just have problems swallowing big pills, who doesn't? Levodopa is not a big pill, but you can crush it up, okay? You can put it in applesauce. It will not lose efficacy, so that's a good thing. People who take the Rytary, which is a newer formulation of carbidopa-levodopa that some of you might have heard about, that's a capsule that can be opened up, and you can put the sprinkles in applesauce. That's easy to take if you have swallowing problems. And we can also actually, your physician can write out a prescription for you or a way to liquefy your levodopa. So there's a way to crush levodopa up, put it in a liter of orange juice or water for the day, and then you would sip on a certain pre-specified amount of milliliters throughout the day. So there's ways to take dopamine in even if you cannot swallow tablets. That's good to know. Now, for people, again, who cannot swallow at all, there's also medicines now in patch form, such as rotigotine patch. I believe there's some vendors outside for the Nupro patch, which is the brand name of that medication if you're interested in learning more about it. But that's a skin patch form of a dopamine agonist that does not require any swallowing, of course, because it's a patch. And then the newest kid on the block, in this country at least, is Duopa. It's a pump delivery system of carbidopa-levodopa that's been available in Europe, where I'm from, for 17 years now, but we're finally discovering it's good for Americans with Parkinson's too. And it will deliver carbidopa-levodopa through a PEG tube that I just showed you a picture of directly into your gut. So no swallowing involved at all. The other great thing about that new medicine for Parkinson is that it will keep your levels of levodopa fairly steady throughout the day, because the pump that is pictured here, that looks like this, will infuse the same amount while you're awake steadily into your system. So a lot of our patients who have a lot of fluctuations to their medicine and who might be consulting our neurosurgeons for DBS, this is an alternative, at least, that one should know about, and can be very effective. And of course, you know, ideal if you can't swallow pills. Now, the last GI symptom we want to talk about is the drooling. The good thing is that it is easy to address. Important to know is a lot of people think, why am I making more saliva? You actually don't make more saliva. You just don't swallow it frequently enough, because as your muscles slow down with Parkinson's and you don't move as quickly, you're not swallowing as quickly or as frequently. So that's why people have drooling. So the way we treat that is there's two very effective ways, and then there's one very not so effective way. The two effective ways are either using a swish and spit formulation of atropine drops. Atropine drops are usually prescribed by ophthalmologists for your eyes. But if you take 1 or 2 drops of that, put them in a tablespoon of water, swish around your mouth and spit out, it will dry you out for a couple of hours. Very useful if you go to a social function, you don't want to deal with excessive saliva, drooling out, and you just take these drops, swish and spit, don't swallow that stuff, not good. But it basically has no side effects if you just use it around your mouth. So that's a good thing to be doing. A not so good thing to be doing is swallowing pills that dry you out, such as benztropines, even a scopolamine patch. Sometimes these are prescribed. They have many, many side effects in Parkinson's disease, such as confusion, constipation, urinary retention. And we don't think that's at least not a good first-line idea. What works much better for people, goodness, when am I learning? For people with bad drooling are injections of myoblock or Botox directly into their salivary glands. So if you think about the salivary glands, they actually sit right under your cheekbone here and under your chin. And they're very easily accessible because they're so superficial. So we can put medicine in there that will block the receptors that are important for your body to make saliva and decrease your saliva production. The beauty is you don't have to swallow a pill for this. It lasts 3 to 6 months. So instead of adding a daily something and swish and spit all day long, you can get relief for 3 to 6 months with one injection. This is covered by insurance, no problem, very effective. So that's certainly something to think about. You can start with the easy swish and spit and then kind of graduate to this if needed. Now, moving on to some practical tips, thinking about other non-motor symptoms that might affect your urinary tract system. Many people with Parkinson's disease have urinary incontinence. And here, it's important to know that your Parkinson doctor is a great doctor, but probably not the best specialist to determine why you're having urinary issues. It is very important to get a urologist on board that can determine what is causing the leakage, especially in men when prostate issues come about, and some of you might have enlarged prostate. I can't determine that. Nor do I want to, but it's not what we're good at. So it's important to get the urologist in there because certain drugs might make it worse if your prostate is enlarged. In women, there might be the situation of a woman who has had a hysterectomy before, there's post-surgical scarring or laxity of the tissue. That all is structural damage or anatomy that we need to know about. So urologists or gynecologists are very helpful in this particular matter. And then it's, again, important to kind of know what to avoid or at least be inquisitive about it when you get started by your doctor, your urologist or gynecologist, or your Parkinson adventurous doctor on some medication. So there's a couple of medicines that we're trying to avoid, which are ditropan and detrol, because, again, in Parkinson's, they can cause confusion and hallucinations. The Parkinson's brain is very sensitive to many medicines that are great for other people who don't have Parkinson's. So you just need to be sensitive about that. And there's many others that are absolutely fantastic and safe to use. So just know that there's a lot of options. We've found in our practice that Myrbetriq is our preferred drug for urinary incontinence that is not related to structural problems. And the reason is because it's so well tolerated. It really goes right to where it's supposed to do its job, which is at the bladder, and doesn't, attach to brain receptors and so on and so forth. So that's a really, really good thing. Now, some of my patients are so incredibly sensitive to pills, no matter what the urologist prescribes, they don't react very well to that. And especially in advanced Parkinson's, we see that. So we're trying to avoid over-medication with pills. So here's another plug for Botox. Botox is a great medicine to treat incontinence and Parkinson's disease if your urologist thinks you're a candidate. The Botox gets injected via a scope into the bladder wall directly. Now, the advantage of that over popping pills is that it stays where you put it. It doesn't go to the brain, doesn't cause confusion, doesn't cause sleepiness, lethargy, and all these symptoms that many of you develop when we put too many medicines in you at once. So using something that stays in the bladder and stays away from the brain is a smart thing. Again, these injections last about 3 to 4, up to 6 months, and might be the way to go. Now, equally important, and actually something that I think should be on the almost most important list right after the pneumonia story, because it can cause harm if not recognized, is the issue of orthostatic hypotension, Parkinson's disease. What does that mean? I was showing you a picture earlier that showed that once that alpha-synuclein protein moves up from the gut, it then hits the lower portions of the brain that have to do with blood pressure regulation. So when you're all sitting down like you are now, and then you're getting ready to get up for lunch, you will stand up. what your blood pressure is supposed to do. Your heart rate is supposed to increase, and your blood pressure is supposed to rise up with you. And in Parkinson's disease, that mechanism is often disrupted. And as you stand up, your blood pressure does not go up. It actually goes down 20, 30 points, 40 points, and your heart rate doesn't go up. So it's wrong. And it's not just wrong because we don't like the numbers. It's wrong because it makes you feel very lightheaded and dizzy, and you might have to hold on to the table or just kind of take a minute before you stand up. But some people with Parkinson's who have this actually pass out every time they stand up. We even have people who can't even sit up because it makes them pass out. So that's a big problem. Now, this is also a problem that causes a lot of falls in Parkinson's disease. When I hear my patient come in, I fell twice this month. I'm trying to figure out why. Did they trip over things? Did they lose their balance? Did somebody push them? But many of them fall because their blood pressure drops. They get lightheaded, and they go right backwards. So this is something that really, really is a serious symptom that we need to take care of. So how do we take care of this? First thing, coming back to what I told you earlier with constipation, we need to eliminate those medicines that we give you that make this worse, right? I want to make you better. I don't want to write you a prescription that makes you pass out. But unfortunately, some of the Parkinson medicines we use actually do this. They lower your blood pressure. Dopamine agonists are some of those. So let me give you examples. That would be Requip or Pinaral, Mirapex, Pramipexole, Nupro, Rotigotine patch. All those things we call dopamine agonists, and they drop your blood pressure. So if your blood pressure drops when you stand up, and I see that you are on one of those, I'm going to take you off of that, because that might just solve your problem and you're done. And then you come out with less medicines and less problems. Wouldn't that be nice? There's other medicines that we use. Quetiapine is one for people who have hallucinations, Artane for tremor, amantadine, all Parkinson meds that can make your dizziness worse. Now, here's the most simplistic thing, but it comes up all the time. I have people who come to my practice, their blood pressure drops, they pass out, but they take a lot of medicine for hypertension. So here's the story for that. They used to have high blood pressure that we call hypertension, right, years ago, 20 years ago. And their home doctor, rightly so, put them on hypertension medicine, hydrochlorothiazide, lisinopril, anything. Worked well. Well, 10 years later, they get Parkinson's disease, but now their blood pressure changes, and it suddenly is lower and lower and lower. But nobody thinks about taking them off of their antihypertensive. So that's the easiest thing to do. You don't need that stuff anymore. You graduated, now you have Parkinson's, blood pressure is lower. We'll get rid of the Norvasc or whatever hypertension med the patient doesn't need. So first we do that before we do anything else. Next step, we're going to come back to our water spigot. So hydration, very important. If you think about blood pressure, you want to fill up that tank. All right, so we'll do that. Those of you who are not diabetic, you might want to add some Gatorade with the electrolytes in there. That's another good way to bring your blood pressure up. Be generous with your salt intake if your internist allows that. And then we've also found that if people sleep with their head elevated at least 30 degrees, their blood pressure is going to be more stable during the day. So there's this blood pressure equilibration thing that happens while you sleep, and you don't even know about it. Your body's smart enough to do that for you. But if your head is elevated at least 30 degrees, your blood pressure tends to be more stable the next day. So that's another good little trick. However, some of my patients, they follow all the tricks, or they don't, and they still have low blood pressure issues. So here we need to come in now with medication, all right? So we're now going to add to the list. The good thing is that we have 3 drugs to choose from that very successfully treat low blood pressure and Parkinson's disease. One is a relatively new addition to the list. It's called droxidopa or Northera. And again, it is used to raise blood pressure. Midodrine is another one, and fludrocortisone is the third one. The important thing to know is, very, very important, never take these medicines after 4 o'clock in the afternoon. Why is that? The reason is you could have an unexpected spike in blood pressure, very high numbers, in response to those blood pressure elevating medicines while you're sleeping, and have a stroke or heart attack while you sleep. All right, so that might be actually something you might want to follow because that is dangerous. It actually now has a lot of warnings if you ever read medication labels. In these particular medicines, there's a big black box warning. It says it can cause hypertension, very high blood pressure when you lay down, and most of us lay down when we're sleeping, so obviously that's a big thing. It's a big warning, so we want to stay away from giving this too late at night. Okay, taking a deep breath here. Coming to a very important thing in Parkinson's non-motor symptoms, which is pain. Now, a lot of people have pain from this and from that, but we need to understand that even just having Parkinson's without having sciatica on top of it and hip problems and whatnot can give you pain. And so please bring it up to your Parkinson doctor because we might be able to contribute here. The most important, so that we can help you, for us is to understand when you have pain. And it might be important to keep a diary of that. Now let me tell you why that's important. There are certain forms of pain, such as muscle cramps, that occur in response to you taking or being due for the next dose of medication. So either taking medicine or being due for medicine again. And so some people, for example, when they develop off time, that means the time when your Parkinson medicine is not working well in your system, develop very painful muscle cramps. Their toes curl, their foot turns in, and that can be very painful. If I know that that happens every time that you are almost due for your next medicine, then I can help with that, and I can add some medicines that make your dopamine last longer. Right? So if I know that that cramping happens about an hour after you take your medicine, then I know it happens at peak dose, and I'm giving you way too much medicine. Well, I'm just going to pull back, and you'll feel better. So there's a lot of relationship between pain and when you take your medicine. But we need to kind of understand that. And it can get complicated because many of you take medicine every 2 to 3 hours. So we need to kind of have a little chart or a diary and know when that pain happens. Some people experience abdominal tightness when their medicine gets low. And we can fix that low if we know when it's happening. So ways to fix the low. For example, I brought up that new medicine for Parkinson's, Rytary, right? So that is a form of carbidopa-levodopa that kicks in quickly but lasts longer. So where your regular Sinemet might only last you about 2 to 3 hours, you might be able to go up to 5 hours now with that. So that's a significant improvement. Doesn't work for everybody. None of this, as you know, Parkinson's is very individual. But some of my patients have done very well with that switch. So that's something, a new improvement to keep in mind. There's also other medicines that have been around a long time, such as Azelac, Stalevo. All those are things that make your Sinemet effect last longer and therefore may be able to cut out that painful sensation that comes on when you're drifting low in your medicine. And then, of course, other ways to treat that, if your Parkinson's is more severe, would be deep brain stimulation or thinking about that Duopa pump and just thinking about keeping your dopamine level constant and avoid the ups and downs, all right? So on the ups, what we mean with ups is when some people have involuntary dyskinetic movements that some of you might get when your medicine is high in your system, all right? That can be very painful as well. These are twisting postures. Can be painful. In that case, it might be as easy as reducing your medications. We might be over-medicating you, or eliminating some stuff that just accumulates in your system unnecessarily, some longer-acting forms of levodopa. And we might need to add something like amantadine, which treats dyskinesia. So we just need to understand when it occurs, and we might be able to help with the pain. Some people wake up with a very painful foot cramp in the morning. So there's ways to address that. We can give you something that works all night to treat your Parkinson's symptoms. So when you first wake up in the morning, you don't wake up with a stiff foot, with a foot cramp. Or we might add a muscle relaxer to your morning medicines or give you a little perk in the morning, such as crushing up your levodopa so that it kicks in fast in the morning after you haven't taken anything all night. All those are little recipes that can help you with painful foot cramps in the morning. Taking your medicine with a carbonated beverage, especially in the morning, makes them kick in faster. Again, most people don't take anything all night, so in the morning they wake up and they're very off, and that can be painful. So taking them crushed up and just with a Perrier seltzer water, if you want to be fancy, or some Coke, makes them kick in quicker, and you get quicker relief. All right? And then some people are really off in the morning, and they might benefit from an apomorphine injection, which is an injectable Parkinson medicine, kicks in very quickly. And then, since I've told you about Botox many times today, I'm just going to repeat myself here, but you need to know that Botox injections into the affected muscles are another very effective way of relieving very painful muscle spasms in Parkinson's disease. Beauty, again, is that it stays where you put it, doesn't lead to central side effects at your brain. And then the last remark on pain is that many people with Parkinson's, of course, have back pain because their posture is not normal. You know, as you know, we develop a stoop posture with Parkinson's disease. We're leaning forward, and we're really pulling and stretching our back muscles. So physical therapy is very important. Some people do well with some forms of braces. I just put that picture up there of this brace because the most common reason for people not to wear a brace is because it's really, really uncomfortable, and if you feel like you can't breathe when you wear one of them. This TLSO brace, for example, as you see in this model wearing the brace, it is not constricting at all. There is a T-bar at the top, which gives the patient a push that makes them stand up and not stoop. And then there is sidebars because many people with Parkinson's lean to the side. That causes even more muscle cramps. So here, you're getting the correction push on the side and on your chest bone, but your abdomen is free to breathe. With many braces, you feel like you're, wrapped up and can't breathe. But with this thing, as an example of one, the TLSO brace, you can actually breathe and get your posture corrected to a certain extent. All right, well, if you want to communicate your pain to your doctor, there's one thing to keep in mind, and that is that Parkinson's disease leads often to a low voice that is not projecting. So then you can either ask for the microphone tune-up like I did a little bit earlier, or you can go to a form of therapy called LSVT loud. Some of you might have done LSVT big for amplify your movements in Parkinson's that tend to get smaller. A very similar principle is, in Parkinson's we know most of you don't have slurred speech, but the speech is just very soft. It's soft, you don't hear it. And so the LSVT loud speech therapy works with you on dialing up the volume. There's two factors to that. One problem is that people with Parkinson's who speak softly usually don't realize they speak softly. So if you don't realize you speak softly, you're not going to speak up. It's because you basically lose that internal perception of your speech and you don't feel that you speak softly. So you learn to yell and shout. It's actually really fun. So just keep that in mind. So once you yell and shout, you become so happy that you forget about the depression, anxiety that we're going to talk about next. But still, even with that loud therapy, people with Parkinson's disease, about 60% of them have depression. It is the most common psychiatric symptom in Parkinson's disease, and people don't like it, and rightly so. It's not a good thing to have. So the question I get from my patients is, well, do I have depression because I really don't like having Parkinson's disease, so that depresses me? Or is it the biology of Parkinson's, the low dopamine, that alpha-synuclein footprint, and so on, that makes me depressed? Well, we can actually show that Parkinson's disease leads to a biologic depression. So all these neurochemicals that are low in Parkinson's, they make you depressed. You're not just bummed out about having Parkinson's. There's many things you can be bummed out about in life, but pick it. But here, we actually have a biologic basis, and we can show that there's often depression onset before the tremor and the walking problems and the stiffness occur. Just like with the constipation and the gut 20 years before, we can show that the depression often starts many years before the motor symptoms occur, all right? We also can show that dopamine deficiency is directly linked to developing these depressive symptoms, and we can show brain imaging studies in Parkinson's disease that show abnormalities related to depression. So it's a biologic problem. We know that exercise improves many symptoms in Parkinson's, including depression. Very important. We also know that supportive psychotherapy, especially CBT, is something that can be extremely helpful to deal with depression and Parkinson's disease. However, in some people, we know that medication treatment is needed. And I earlier told you, dopamine medicines don't fix the mood problems and the non-motor problems in Parkinson's disease. Mood is a little bit different. We know that if somebody is not treated with any dopamine, they're very dopamine deficient, their mood is going to be worse. So giving you some dopamine already has a mood elevating effect. And actually the dopamine agonist, the pramipexole, ropinirole, they do have an antidepressant effect. So that's a good thing. But in most people, we need to actually go to actual antidepressants that are safe and approved by the FDA to be used for depression to treat Parkinson's-associated mood problems. The good thing is they're very, very effective. Essentially everything that you see here, which is almost every antidepressant that's on the market, has been looked at in Parkinson's disease, and we find it very effective. So we're just going to try one that we think where the side effect profile is most favorable to you as an individual, or something that a relative of yours has done well on. Interestingly, if your sister has depression and does well on citalopram, there's a good chance you will do on it as well. There's a genetic linkage here. So certain families do better on one than on another, interestingly. So usually, you shouldn't share medicine between relatives, but that might be one where there's an exception. There's a few things I want to point your attention to. Certain meds that are used in psychiatry, not directly as antidepressants, but sometimes called mood stabilizers, that worsen Parkinson's, very much contraindicated in Parkinson's disease, either worsen the tremor or Parkinson's itself, so stay away from those. Anxiety, equally common, just like depression. Now, here's another reason to be keeping a diary. Anxiety can come on with off time. That might be the first warning that you're about to turn off. So your medicine cycle might be such that you're almost due for your next dose of medicine, and here you get anxious, all right? Same thing, you use the same drugs. These antidepressants work beautifully. Psychotherapy works beautifully, and it's not your fault to be anxious. It can just be a result of your Parkinson's disease. Something that makes us very anxious a lot of times is to think about cognitive ramifications of Parkinson's disease. I want to point out that cognitive changes in Parkinson's are very, very common, and they occur early in the disease. However, what we see very early in the disease is something we call mild cognitive impairment, not dementia. We see mild cognitive changes in most people with early Parkinson's. And I told you earlier that that picture is very similar to what adult attention deficit disorder would look like if you had it. You have trouble paying attention, you're not focusing as well, you have some trouble multitasking, but you're carrying on your daily activities. It's just more challenging on your brain. It wears you out to plan a party, plan the symposium. You don't want to get it's very hard, and it's not your baseline, but you're still functioning well. And then some people actually develop dementia down the road. But the risk factors for developing that is increasing age, longer disease duration, and higher disease severity in a motoric sense. So that progression to dementia occurs in about 40 to 60% of people. And what we are working on in research is to find ways to stop the mild cognitive impairment at the mild stage and not let it slide to dementia. What we have found is that there's one thing that keeps people's minds from being impaired, and it's a very simplistic and very, very good thing to be doing. It is social engagement. You will hear a lot about you should be working crossword puzzles and Lumosity and online games. That stuff is fine and dandy, but if you think about how many neurons you're working when you're actually at a family reunion talking to your crazy relatives, it is much more of a brain workout than any puzzle that you would do in seclusion in your room. This is what you want to do, which is why it's so important to get your voice up to speed with LSVT loud so your lovely relatives can hear you. Exercise. Good indication that exercise improves cognitive function in Parkinson's disease. I'm glad you will hear about the kickboxing later on, because the Rocksteady boxing, there's some upcoming data from our research group that it will improve cognition in Parkinson's disease. So keep that in mind, social engagement, exercise. Now, when it becomes a little bit more noticeable to a point where you don't, you can't carry on conversations as well, and you say, well, social engagement, I have trouble finding my words. It's not as easy as you say, doctor. Well, then I know I need to help you with adding some medication. Again, the good thing is that there are medicines that we kind of borrowed from our colleagues in the Alzheimer's world, but that now also have shown to be very good in Parkinson's cognition, which are rivastigmine, donepezil, galantamine, Exelon, Aricept, Razidine. Those medicines are especially good for word-finding problems. I find, I've had some people say as much as, I have my mother back because now she can communicate better, at least for a while. They don't cure dementia, but we can improve communication problems due to thinking problems by much with using these medicines, and we really like doing that, and we like to do it earlier than later because they seem to preserve memory function to a good bit. There's also a lot of research going on in this area, so hopefully there'll be more approved drugs soon. And there's another drug that some of my patients are on that's called memantine or Namenda. We don't have good data in Parkinson's on this drug, so I don't particularly prescribe it. So just be aware that there's no data on that being helpful in Parkinson's disease. Now, here's another thing, hallucinations. Some people, especially with cognitive impairment, develop hallucinations in Parkinson's disease, and there are a couple of very, very important take-home messages. If you or your spouse who has Parkinson's experiences something like seeing something run across the busy patterned carpet here, and you're trying to check if that's real or not, that might be a first symptom of a hallucination, and that's not something to be shy about or not to be talking about. It's important you bring that up. You might have the feeling somebody's standing behind you, and when you check, there's nobody there. We call that a presence hallucination, very common in Parkinson's disease. You might hear some indistinct noises coming from somewhere, and you check where they're coming from, and there's no source for the noises. We need to hear about that. The first time that happens, we're going to check you and see if there's maybe a medical illness, like a urinary tract infection, bringing these symptoms on. All right, that's very, very common. So we'll do that, but most of the time that's not the case, and these hallucinations are due to you having Parkinson's, which we already knew, and you taking Parkinson medicines that we are prescribing and we also know about. So we shouldn't be too surprised that that happens because we know it can. It can be happening in Parkinson's disease and you taking certain Parkinson medications. Risk factors are very similar to dementia, advanced age, advanced disease duration, but also poor sleep and a history of depression put you at higher risk for hallucinations. So these hallucinations are usually initially very benign. In other words, the patient knows they're not real. I see something on the ground, and I know it's not real, I'm not going to go pick it up. But unfortunately, if we let this slide and don't address it, in 3 years, my colleague Dr. Getz from Chicago has shown that 80% of people who have these hallucinations lose that insight and start believing that these things are real, which can cause significant problems. Also, actually, a lot of problems on the caregiver side. This slide is small to read and small print. I apologize for that. But basically what it's saying is that hallucinations in Parkinson's disease cause a significant burden on the caregiver. We need to think about that as well, because it's very disturbing to be constantly arguing, is this real? Is this not real? I know it's real. I know it's not real. That's not a motivating thing for a relationship to be struggling with constantly. So we need to treat them and address them. First thing, like I said, you want to make sure there's not a medical illness causing them. We want to reassure the patient, of course. And here we come again. We want to decrease certain Parkinson medicines. We already did that for the blood pressure, and we did that for cognitive decline. We did that for constipation. Here we are again. Many of what we give you can cause hallucinations. Dopamine agonist, again, first thing. Artane, amantadine is always the same ones, right? Which is why we really find that Cinemet, after all, is the best drug we have. A little plug there. But it's true. So we want to make sure we're not over-medicating our patient and causing hallucinations. But in some people, we'll just have to give medicine to downregulate these hallucinations. And until very recently, we only had 2 choices, both of them not approved for Parkinson's. One was quetiapine and one was Clozaril. But just a few months ago, Nuplazid was approved by the FDA specifically for hallucinations in Parkinson's disease, the only drug that's approved. Generic name is pimavanserin. Very good drug, minimal side effects. There's one thing to know about, it takes about 6 weeks to get in your system. So if I have a patient who's truly in crisis, and I give them a medicine and say, in about 6 weeks, you'll start feeling better, that oftentimes can be a problem. But we need to put that information out there, because otherwise you'll stop taking it after a week and say, oh, that stuff is not helpful. But if you start these a little bit earlier, before the crisis is there, that's why I'm saying it, you don't want to wait until crisis is there, because this stuff takes a while to get in your system. If we are proactive and we see the writing on the wall, we might want to start medicine then, all right? But we still have the 2 older drugs as well that are helpful. But a great new advancement here. I'm very happy we finally have a drug that's approved for this scenario, because this is scary stuff. It does affect the patient as well as the caregiver, all right? So here's my summary. Parkinson's disease has many faces. It is not just tremor. It is not just stiffness. There are many non-motor symptoms, and they're usually perceived as more disabling than the motor symptoms are. We have already a better understanding of why they're occurring, because that protein clumps up in places in the body, outside of the brain and inside of the brain, where we know these non-motor symptoms originate. We have made some advances recently in improving drugs that help with the management, such as the blood pressure one that's new, the Northera, the hallucination one that's new, the Nuplazid. The Exelon for dementia has an indication for Parkinson's disease as well. We are currently doing more studies on non-motor symptoms in Parkinson's disease. So at the next symposium next year, we might add to that here's more new medicine list, which is very, very good news. The only way to get these drugs on the market and on this list is for you all to participate in clinical research studies. I believe at UB you're doing clinical trials in Parkinson's disease. They are starting to accumulate them, and if they're starting to accumulate them, they need study participants. With no people in our studies, we'll never find the cure, and we will never find better treatments for non-motor symptoms. We're so thankful we've made these advances, because people do participate in research, which is amazing. So thank you very much. This is a big topic to be talking about, and I'm happy to take your questions now. There will be microphones traveling to you if you raise your hand.
Check. All right. We're going to take just a few questions now. This was a boatload of information, but we do need to move along, and so we may hold some questions until the very end. But we will take a few questions now.
Thank you. You mentioned the frequency of urination with PD, but how about when you can't urinate and you have to bear down to urinate?
So the question here is, what about urinary hesitancy, not being able to get the stream going? That points to 2 things. It's very commonly a medication side effect. There's medicines that will stop urination, and so we need to go through that medicine list. Your doctor will immediately be able to pinpoint which ones those are, maybe mainly the anticholinergics, Artane, amantadine in Parkinson's disease. And it also points to structural causes. So in men, it would be prostate enlargement. In women, there can be structural causes related to uterine issues as well.
You don't think it's from the Parkinson slowing up that process?
No.
Okay.
My question is urinating too frequently. Say like every other hour throughout the night, pretty much through the day. I addressed this with my urologist, and he wants to further study this because he can't give me an answer. He put me on medication to go more frequently because I have a problem with tumors in my bladder, which he removes every 3 months. I had a kidney taken out on the right side. So the question is, how can we slow down the urination?
So you seem to be keeping your urologist busy, it sounds like, with your problems. So yours are more complex than the usual just due to Parkinson's. There's probably a contribution of Parkinson's disease to your issues, which induces the frequency, but because you also have bladder tumors and other structural issues, not going to be as easy. So in Parkinson's disease, we know that drugs like the Myrbetriq slow down that urgency, so that's a good way to go. Like I said, Botox injections can slow that urge down as well. Now, some patients, they try everything and they still get up every hour in the middle of the night, which is a great risk for falls, and we don't like that. And from a simplistic side, again, coming back to that, what we find very helpful is using a condom catheter in men. So condom catheter, non-invasive at all. You just pull it over the structures involved, and you don't have to get up every hour anymore and stumble and fall in the dark. It is sometimes much better than, adding medicine and medicine, so sometimes simple is a good thing. But yeah, yours seems to be very complex because of the structural issues involved.
Yeah. Can I just inject one more question?
Sure.
What's your feeling on medical marijuana with Parkinson's?
Sure enough. So medical marijuana and Parkinson's disease is not well studied at all. We essentially don't know anything about it. It's a very complex issue. The reason why many Parkinson's scientists are not gravitating towards studying it is that regular cannabis in the form that we most recreationally know it has been proven to be harmful to certain areas of the brain that are involved in Parkinson's disease, can cause permanent damage to the attention, concentration, and executive function networks in the brain. And so to be thinking about using a drug that can be permanently harmful to people's thinking and cognitive ability in an illness where we already have these problems is kind of counterintuitive to what we want to do for our patients. One more question?
All right, we'll do one more question now, and then we'll move on. We'll have more questions at the end.
What about the results that you get from the scan? I talked to those people up there. How well does it work?
You're talking about the scan for depression?
No, the
Oh,
scan to determine if you have Parkinson's or not.
Oh, you're talking about the DAT scan where there's a representative outside? Right. Okay, so DAT scan, this is a diagnostic scan we use to image people where we suspect Parkinson's disease, but we're not entirely sure. That is a rare case scenario. Most of the time, if you are lucky enough to be paired up with a movement disorder specialist, your movement disorder specialist can make a clinical diagnosis, and we do not need the DAT scan. However, some people like you with your urologic issues are very tricky with their neurologic issues, and we can't make a clinical diagnosis without help. In that case, we can refer the individual to have a DAT scan done. That is a scan where you get injected with a medicine that travels up to your brain and binds to your dopamine system. And when you're in the scanner, your dopamine system will light up. If you don't make enough dopamine, it's not going to light up as robustly, and the radiologist will tell us as clinicians that there is dopamine deficiency. There's about a 15% error rate in that scan, so the scan by itself cannot make or undo a diagnosis. It has to be taken together with the information from the movement disorder specialist. So this is not a test to be done in everybody in the general population to screen for Parkinson's, but if the specialist has a doubt, it's a great tool to reassure us that we are on the right way with our diagnosis.